My name is Bridget Ellsworth from Medical College of Wisconsin in Children's Wisconsin, and I'm going to be presenting on the use of femoral nails to treat pediatric femur fractures. Pediatric femoral shaft fractures make up about 1.5% of all pediatric fractures, with an annual incidence of 19 fractures per 100,000 children. These fractures, by definition, occur in the shaft of the femur, which is outlined in the X-ray on the right. The femur is a cylindrical bone analogous to a PVC pipe with a solid outer shell called the cortex and a hollow center called the intramedullary canal. When we talk about placing nails in the femur, they are placed into the intramedullary canal to hold the bone in place as it heals, as shown here. Pediatric femur fractures can be treated in a variety of different ways, including Pavlik harness and spica casting in young children, flexible and rigid intramedullary nails, and plate fixation. The surgeon will make the decision about how to best treat the fracture based on factors such as the age of the patient, the size of the patient, the fracture pattern, and concomitant injuries. Young patients under the age of 5 years have greater potential for remodeling, meaning they will heal well even with a bone that is not perfectly straight, and also heal very quickly. For these reasons, young patients are more amenable to treatments that do not require the use of incisions or implants, such as Pavlik harness treatment and spica casts. There are some cases in which patients younger than 5 may benefit from implant placement, and these are usually in large patients with displaced fractures or those who cannot tolerate a spica cast, as flexible nails are typically more convenient for the family in these scenarios. Plate and screw fixation is usually used in patients who are older than 5 with a fracture pattern that is not amenable to flexible nailing, but who are too small for a rigid nail. This talk will focus on flexible and rigid intramedullary nails. Flexible nails are used in school-age children who are lighter than 49 kilograms or 100 pounds. The use of this technique depends on both the size of the child and the fracture pattern. It works best for fractures that are transverse or straight across, as shown here, as these types of fractures are at lower risk of displacing or shortening after the nails are placed. In fracture patterns that are high risk for shortening, plate and screw fixation may be preferable. The nails are placed through small incisions about the knee or hip and are left below the skin but above the bone to allow for later removal. Flexible intramedullary nails are not as stable as rigid intramedullary nails, and therefore additional immobilization, such as a cast or splint, may occasionally be required after surgery to ensure that the fracture heals in the intended position. They are not as stable for a few reasons. The first is the size of the nails are small to allow them to be placed in smaller femurs, and the second is that there are no screws above and below the fracture holding the rod in place. For this reason, there may be some movement or rotation at the fracture site following placement of flexible nails. Because of this, weight bearing is usually restricted following fixation for the first few weeks after surgery to allow some fracture healing to occur prior to weight bearing. However, some fracture patterns in small children may be amenable to immediate weight bearing. A second surgery to remove the nails is typically recommended approximately a year after the fracture is healed, since the implants can become buried in the bone as the child grows if not removed. Rigid nails are bigger, stronger implants than flexible nails, and rigid nails are used in children as young as 8 years old. Rigid nailing is the standard of care for the treatment of femoral shaft fractures in adults. The use of this technique depends on the age of the patient and the intramedullary canal diameter, as shown here. Again, the femur is a cylindrical bone analogous to a PVC pipe with a solid outer shell called the cortex and a hollow center called the intramedullary canal. The canal must be large enough to accept available rigid nails, and this can be a limiting factor in small children. Additionally, a rigid nail must cross a growth plate that is active until a child is about 8 years old, and this also limits use in younger children. Rigid nails are placed through small incisions about the hip, and additional small incisions are used to place the screws through the nail above and below the fracture, which locks it in place. This additional stability allows for less immobilization after surgery and the ability to place weight on the leg immediately following surgery in most cases. Patients usually require assistive devices such as crutches or walker to prevent falls following surgery. Patients may be provided a brace to assist with ambulation since the quadriceps muscle is weak after a femur fracture. Removal is sometimes recommended if the implant is symptomatic or at the discretion of the surgeon, but it is less routinely recommended than flexible nails. The vast majority of children with femur fractures heal uneventfully and return to their original activity level within a few months following the injury. Physical therapy may or may not be recommended depending on the patient's progress and goals. Return to sport is usually around 12 weeks, but can vary based on the individual patient. A child who is treated for a femoral shaft fracture may limp for several months following treatment. This is expected and resolves over time as the muscles grow stronger. Possible complications of intramedullary nailing are similar to complications of any surgery and include bleeding, infection, and neurovascular injury, which are rare. Risks specific to fracture treatment include non-union, meaning the fracture fails to heal, delayed union, or the fracture healing is slower than usual, and malunion, or the fracture is healed in a position which is not completely straight. These are also rare when treating femoral shaft fractures in children. Risks specific to femur fracture treatment include limb length discrepancy due to the fracture healing in a shortened position, symptomatic implants, which may require removal after fracture healing, or refracture of the femur following implant removal. In the case of flexible intramedullary nails, the end of the nail sitting outside of the bone near the knee may irritate the soft tissues and lead to knee pain and/or stiffness while the implants are in place. AVN, or avascular necrosis, of the femoral head is a loss of blood supply to the top of the femur bone. This has been reported with the use of rigid nails designed for adults and young children, but it is very uncommon with the use of pediatric-specific nails. Overall, complications are rare during the treatment of femoral shaft fractures in children. Thank you.